Sorry?
Yes, sir. You can go ahead, sir, please.
Okay. Good afternoon, everyone. I welcome you all to the 7th and last session of the Phaco Masterclass series with Professor Mohan Rajan, sponsored by Johnson & Johnson Vision. Let me begin by introducing myself. My name is Satish Thomas. I'm currently working as Professor and Head of Ophthalmology at Believers Church Medical College, Tiruvalla. I was formerly Professor and Head of Ophthalmology at Christian Medical College, Ludhiana. I did my MD Ophthalmology from RP Center and then fellowship in Pediatric Ophthalmology and Strabismus from Shankar Nethralaya. Over the past 20 years as a faculty, I've been involved in training many students in ophthalmology and phacoemulsification. Today's session is on a most important topic, but before that, let me introduce Professor Mohan Rajan. I really don't think that is necessary except as protocol because there'll be no one attending this session who does not know about him. Professor Mohan Rajan is the Chairman and Medical Director of Rajan Eye Care Hospital in Chennai. He is the President-elect of Tamil Nadu Ophthalmologic Association, Visiting Professor at Savitha Medical College, Past President of Intraocular Implant and Refractive Society of India, Secretary of the Shankar Nethralaya Alumni Association, of which I too am a member, and the member of Scientific Committee of the AIOS. He has presented more than 2,000 papers, published 42 articles, delivered 25 named orations. He has performed more than 120 live MICS surgeries and has won several Best Video Awards at prestigious international conferences. He is an all-rounder in the sense that he's both an anterior and a posterior segment surgeon. For lack of time, let me stop short here. I believe this is the most important of the 7 series webinar we are having because it is here that we can gain maximum from someone of Sir's caliber. When things go well in surgery, the difference between a novice and a master cannot really be appreciated. But it is when we watch the masters handle difficult situations that we can really appreciate them for their skills and learn much from them. So if you have any questions, please type them into the chat box and we will take them up at the end of Sir's talk. So let me invite Professor Mohan Rajan to give his talk on handling phaco complications. So.
Thank you, Satish. Shall I share my screen now?
Yes, sir.
You're able to see my screen?
We can, sir.
Is my screen visible?
Yes, sir.
Okay. Good afternoon, everybody. And let me at the outset thank my very close friend, my colleague, Dr. Satish. He is also from the same alma mater as I am, Shankar Nethralaya, for the wonderful introduction. Thank you, Satish, for being here, for moderating this session. And of course, I had to thank J&J for this wonderful opportunity. It's been a really an exhilarating experience for me doing these 7 webinars. And each of these webinars have covered some very important topics. And these are my financial interests. As you know, we started with the Phaco mission. Then we also dealt with the importance of wound construction. Then the 3rd class was on capsulorhexis and hydro procedures. Then we had the nucleus management, the different chopping techniques, divide and conquer, stop and chop, epinucleus and cortical aspiration, which is again very, very important step as far as phacoemulsification is concerned. Then different IOL implantation techniques, which we covered last week. And this week we are going to cover, and this is going to be the last of this series, which is going to be the handling the phaco complications. And handling the phaco complications is very necessary. And if you handle the complications and give optimum results to the patient, and that is exactly the difference between an ordinary and an extraordinary surgeon. let me see here.
Capsular X,
This is the Argentina flag sign, as you know.
Pressure,
It's a very intermittent cataract because of the interlenticular pressure. This Argentina flag sign, of course, can be prevented. We talked about during the capsular rhexis, but again, I will just give you this thing. But once you get an Argentina flag sign like this, because of the high interlenticular pressure, the normal dilemma for the surgeon whether to continue with the phaco emulsification or convert into an ECC or an SACS. My suggestion is, if it's a very hard brown black cataract, please convert into a SICS or an ECC. Otherwise, if it's a grade 2 cataract or a softer cataract like this, what you see, you can convert one half of the Argentina flag sign into a semicircular rhexis, as what I'm doing here. And then the other half also you can convert into a semicircular rhexis and try to make sure there are no flaps flying around in the anterior chamber during phaco emulsification. Then what I do is, with a very, very minimal manipulation, I do a direct chop technique. I use the vertical chop directly and making sure that I chop the grising and making sure there is no stress on the, especially on the 6 o'clock tear, which are likely to go across the equator into the posterior capsule as well. Try to bring this nucleus up into the iris plane, or sometimes even in the anterior chamber, making sure that you inject viscoat or any dispersive viscoelastic for that matter into the anterior chamber to protect the corneal endothelium. And now and then, nowadays, I don't mind losing a few corneal endothelial cells, but I don't want the tear to go into the posterior capsule and nucleus and go into the vitreous as well within a millisecond. You can see here, and I'm injecting a foldable single piece lens so that positioning the lens in such a way that is away or 90 degrees from the tear what you see in the Argentina flag sign. You can use a 27 gauge needle or a 26 gauge needle or even a 30 gauge needle and aspirate the cortex which is there in the front compartment, going through a very small opening. The intercapsular or interlenticular pressure is the main problem in Argentina flag sign. Once you decompress the anterior compartment or the front compartment, then you can go around and do the capsular rhexis without any problem. Or if you have access to the catalyst or the FEMTO, you can do the FEMTO rhexis, which I'm doing for all the mature cataracts nowadays, because it's almost 100% foolproof. Only thing is, watch out for skip areas and making sure the skip areas are not there, and making sure, because sometimes there can be small attachments, but more or less you can get a free flap in this femtorhexis. Or you can use septorhexis or develop a technique called punchorhexis, wherein you go bevel down with a 15 degree or a 30 degree tip or a 0 degree tip and punch the anterior capsule, same time give some phaco power which can emulsify the nucleus as well, and then you can make an opening which will decompress both the front and the back compartments. These are parameters I use when I have do the punchorhexis. So this is the way you can manage this Argentina flag sign. As I told you, the take-home message is very, very clear. The take-home message is that if you have a very hard brown cataract and you lose the capsule, please convert, and or you can get this nucleus up, depending on your experience, get this nucleus up into the iris plane. I normally do that, but making sure, because we have a hard brown cataract, if you don't use proper techniques, there's a possibility the cornea can become white. And that is the reason why I always say, especially for beginners, to convert. Again, you can see an escaping rhexis. When you see an escaping rhexis like this, if you try to pull the rhexis in the same direction, it can go towards the equator, towards the zonular area, and you can lose the rhexis, and you can have a problem of rhexis tear extending across the equator. This is called the little rescue, Brian Little, which has been described by Brian Little of UK. And you can see here, I'm trying to do the rhexis when it's extending and trying to pull the rhexis in the same direction as I made the rhexis itself by flattening that rhexis with the OVD, preferably high molecular weight viscoelastic like Hyalon GV or Hyalon, and then try to pull the rhexis. Once you pull the rhexis the same direction, the rhexis, the escaping rhexis can be brought into the center, and then the rhexis can go around without any problem at all. This is called the Little's rescue technique for escaping rhexis, wherein you flatten the flap and then try to pull the rhexis in the same direction as I told you in this particular thing. If you have a problem of dense brown cataract, you can have a problem of white cornea the next day. If you do use the technology, we discussed this different technologies in the nucleus management and during the chopping techniques. But the problem is this corneal burn. If you have an excess phaco energy, or if you have a tight wound, or if you have not removed the viscoelastic or the viscoat especially, and try to give the phaco power, these corneal wounds can be very, very dangerous because can produce irregular astigmatism, wound gaping, infection, and even inflammation, recurrent inflammation. Because these corneal wounds, there is a wound gape, and also there is an ingress of fluid from the conjunctival sac into the anterior chamber as well. This is a corneal burn. You can see I have put multiple sutures. Still, I'm not able to close the wound. And you can see here, this is the way you need to manage a corneal burn. Of course, prevention is better than cure. Prevention and awareness of this corneal burn is very, very important. But don't leave the corneal burns like that. Make sure that you put 2 or 3 sutures there, because otherwise these corneal burns can leak and produce some severe problems. In this patient, I even put, you can see here, despite the fact that I'm put 3 sutures, the wound is still leaking. Then I'm putting some glue as well, and the patient did very well. But this is very, very important that on the table itself, instead of having it post-operatively, on the table you recognize this corneal burn and put multiple sutures, and sometimes you can even put a glue. And this, again, you can see here the arcuate incision I made with the FEMTO, and I put this incision also, our main phaco incision also in the same place. You can see how the arcuate incision is leaking. If you have leaky wounds, please come out of the eye and put sutures and then go inside. Don't try to do the phaco emulsification with leaky wounds, because the leaky wounds, there can be shalling of the chamber, there can be problems in handling the nucleus, and there can be problem with the corneal endothelium as well. The chamber stability will be a problem. The posterior capsule can come forward and you can have posterior capsule rupture. And as you see, you can see the dense brown cataract. I did the phaco emulsification, the FEMTO. Already you can see the cracks on the nucleus extending all the way to the posterior nuclear plate. And then the rest of the this thing becomes very, very easy as you see that. You can see that I put 2 sutures for this thing, and still the main wound is leaking, but I'm going ahead with the surgery and putting a suture for the main wound also at the end of the surgery. Again, you can see the Descemet's membrane detachment. This is not an uncommon problem, but if you see a Descemet's membrane detachment, and if you see a limbal corneal edema post-operatively on day 1, then there are 2 possibilities. One is a condition called TAS, or toxic anterior syndrome, or other one is called the Descemet's detachment. If you have a Descemet's detachment like this, you can see here, if you do a thorough slit lamp examination, you can actually see the Descemet's. These are pre-operative and after the air injection, the post-operative picture. But more importantly, if you have access to anterior segment OCT, the anterior segment OCT will tell you whether it's a simple corneal edema secondary to a DAS or because of excess phaco energy, having used a phaco energy for a hard brown cataract, and that can also cause a corneal edema. But normally that doesn't cause a limbus to limbus corneal edema. As you can see here, there's a total Descemet's detachment in this particular case, the anterior segment OCT, and I went ahead and did an air injection. You can see here in this particular case, this is a very, very tough cataract, and I had a Descemet's detachment as well. And you can see here, this air is injected through a 30 gauge needle. Once it go through the clear cornea, there is opposite to the detachment. Wherever the detachment is opposite quadrant, you always fill up the entire globe, entire anterior chamber, and then come out making sure it is watertight or airtight or whatever it is. and making sure that air does not escape. And put the patient in the prone position at least for 10-15 minutes, and the Descemet's will get attached. You can see that post-operatively the picture. Again, the air injection, you can see here, this is a Descemet's attachment, which is localized. So went ahead in the opposite direction, and you can see, and I'm using a 30 gauge needle here and trying to inject the air into the anterior chamber. And there is this identification of Descemet's attachment is very important. And if you have an identification, if you have Descemet's attachment, if you see a flap floating around, then always make sure that you inject good viscoelastic and go ahead with the slow motion Phaco so that you don't chew up the Descemet's during the Phaco emulsification. Posterior polar cataract, as you know, the Phaco in the posterior polar cataract, the increased problem because of the pre-existing tear, increased incidence of PCR, nucleus drop, there's a plaque on the posterior capsule, which may be difficult to remove. Whenever you see a mature cataract to the posterior polar cataract, always look at the fellow eye. The fellow eye has got an anterior chamber IOL or a lens in the sulcus or an iris claw lens, something like that. Always suspect a posterior polar cataract and do very careful in doing hydrodissection in this case. This is an young fellow, about 42 years old. You have a posterior polar cataract. Preoperatively, I couldn't see any dehiscence, but you can see here I'm doing just an hydrodelineation. You can see here the hydrodelineation, you can see the golden ring. Do not attempt to rotate the cataract or rotate the nucleus, very, very important. Use low flow parameters. But as I am removing as you saw, because as a young person, the nucleus is not very hard, and using a lower Phaco parameters or a slow motion Phaco, injecting viscoelastic every time I come out of the eye to prevent the posterior capsule from coming forward, and then went ahead with the coaxial irrigation aspiration. And then I noticed there is a tear in this is actually a pre-existing tear. You can see that, very typical of the posterior polar cataract. Once you notice the tear, switch over to the bimanual. Always inject a dispersive viscoelastic like Viscoat. Always remove the vitreous which is there in the anterior chamber. Preservative-free tricot should be used. In this case, I didn't use because the patient had a family history of glaucoma. Always remove the vitreous there, and you can interchange, inject Viscoat or any viscoelastic or Hyalon for that matter. Dispersive will be much better and come out of the eye, and then you can go ahead and you can see the typical two pillars on the posterior capsule, which is very, very typical of a posterior polar cataract dehiscence. And you can go ahead with the implantation of the lens, a multi-piece lens in the sulcus, and capturing this lens into the, you can see here, I'm putting the multi-piece lens in the sulcus. Either a sensor acrylic or a MA60 lens can be used, and a foldable lens. You can see the lens, the haptics are in the sulcus, but the optic is captured into the capsular excess margin. If you look at the this thing, you can see this is the optic capture. This optic capture makes sure the lens is back in the bag and prevents UGH syndrome, also maintains long-term centration. The endpoint is the ovalization of the anterior capsule, which is again very important for you to understand this. And this makes the lens very, very stable. And the long-term centration, you can see that 2 months, 6 months, 2 years after the surgery, the patient is having excellent visual acuity. And more importantly, you can see that lens is well centered. It is not moved a micron because I've done the haptic capture. So don't leave the lenses in the sulcus, a multi-piece lens, especially when you don't have posterior capsule and you have a good anterior capsule there. Again, a FEMTO posterior polar cataract removal, this thing, wherein I have done, it's an young girl, I've done only hydrodelineation, you can see here. I've done the advantage of the FEMTO, the catalyst, is that it removes the cataract because it cuts the cataract into smaller pieces. You need to go in and just remove it. As I told you, the same protocols apply here also. Every time you come out of the eye, inject viscoelastic, whatever viscoelastic you have, whether it's you have HPMC, Hyalon, or Visco, whatever it is, then go ahead. You can see there's a dense plaque on the posterior capsule. You can't leave this plaque because you can't yak these plaques, very difficult. So what I do is I do the plaquectomy. I remove the plaque, and I'm doing something like a bimanual technique and trying to remove, making sure there's no posterior capsule tear, not damaging the posterior. You can see that bimanual, and you can see that plaque is also removed. And they went ahead and put a symphony lens in the bag without any problem. So you can, many of these plaques can be easily removed. If the plaques are not very, very thick, you can probably leave them alone, probably yak them later. If plaques are very, very thick, then it's better to remove it on the table than do a YAG capsule. It's very difficult to do the YAG laser because it involves a lot of energy and a lot of pitting of the lens can also occur. The posterior polar cataract, the pearls, peribulbar, parabulbar anesthesia, rexis 5 or 5.25 because you want oval rexis is what has been recommended by Kiranjit Singh. Hydrodelineation, femto delineation, slow motion phaco, low flow parameters. Do not attempt to rotate the nucleus. Inject viscoelastic every time you come out of the eye. Bimanual IA gives you better stability and better access, especially in posterior polar cataracts. Avoid topical anesthesia, avoid order dissection, anticipate PCR, bimanual techniques, stick to protocols, very, very important. PCR, posterior capsule rupture, as I told you, is a very, very important. Anticipate PCR in traumatic cataracts and cataracts post-vitrectomy, posterior polar cataracts, dense brown cataracts, pseudo-exfoliation. All these are, in fact, you need to have a plan A, plan B, plan C before you operate on them. When you have PCR, this is an animation which has been given by Dr. Bobby Osher. And you can see here, when you have a PCR, if you use coaxial irrigation aspiration, coaxial means that the irrigation and aspiration are in the same port. Then what happens is that more and more vitreous gets hydrated and starts coming into the anterior chamber. That gives traction on the macula and the vitreous base as well. And what is initially a small tear can become a very huge tear. But when you have a bimanual, when you have a PC tear, you separate the irrigation from the aspiration. That is called the bimanual, or you have an anterior chamber maintainer. Then we can remove the vitreous which is there, present there. The anterior chamber, the fluid tampons the break and prevents the break from enlarging, and also making sure that the vitreous is not hydrated, and whatever vitreous is there in the anterior chamber, the pupillary area, we can try and remove it by means of the vitrectomy. So this is a patient, they had a PCR, one of my Phaco trainees. You can see here, the biggest mistake is to catch the posterior end of the cortical fiber. And you can see there's a huge PCR, and also one of the nucleus is going back. You can see that the nucleus is going back. And more importantly, when you have PCR, everybody becomes jittery and do not pull out of the eye. Very important. If you try to pull out of the eye, what will happen is the PCR will enlarge and more vitreous will start coming into the anterior chamber. Immediately I went in, I did a bimanual anterior vitrectomy. Bimanual means the cutter is separated from the aspiration, from the irrigation, or the aspiration is separated from the irrigation. The irrigation is on the left side, or you can even have an anterior chamber maintainer. To my luck, what has happened is once I did the vitrectomy, the nucleus also came up, and which I supported. Nowadays I use the IOL scaffold, but you can just support it with the irrigation and try to again remove the vitreous which is there in the anterior chamber. At that time in 2007, the tricot was not available. Otherwise, I would have used the tricot. But more importantly, you can see that bimanual, always remove the vitreous first and then remove the cortex and the epinucleus. Once I have done that, then I have removed the cortex and then went ahead with the implantation of a sensor acrylic 3-piece lens in the sulcus, and the patient is still doing very well after a 13-year follow-up. Mainly because I have followed all the protocols when you have the PCR. You can see here, this is a PCR because of the surge. You can see here, there's a small PCR, which is dense brown cataract. And because I'm using a second generation Phaco machine, a long time back, this patient came to me and this PCR occurred. You can see here, I'm trying to remove that piece and there is a small PCR, which you can see just like a posterior capsular rexis. But what I did, I didn't lose my calm. I injected viscoat into the anterior chamber and stabilized the anterior chamber and then gently removed the probe from the eye. Once you stabilize the anterior chamber, create a right side port and go in for a bimanual. The viscoat goes and plugs the PC tear and also prevents the vitreous from coming forward and also making sure that the antihyaloid is not ruptured. Then I went ahead and did a bimanual IA. Then I found there is some vitreous stand and did an anterior vitrectomy. But more importantly, you can see the PC tear, whatever was there in the beginning, it is the same PC tear. It's about 2 millimeter tear, which is there in the end also. I went ahead and put a multi-piece lens into the bag, and the patient still doing very well with a 6/6 N6 follower. Again, a posterior polar cataract. I just want to show you another patient with a posterior polar cataract. I'm going ahead with the rhexis, making sure the rhexis is not very large in posterior column. Don't make it very small also. Again, I'm doing a gentle hydro delineation in this case. This is a little older patient. He had a fairly dense, about grade 2 nucleus as well. And they were going ahead and doing what is called a slow motion Phaco and trying to rotate this. So the FEMTO is an advantage. In this case, I didn't use the FEMTO. This was done quite some time back before I got the FEMTO. But nowadays, for all the posterior polar cataract, I'm doing the FEMTO catalyst, which makes life easier. When I remove the epinucleus, you see this thing underneath. There is a huge tear in the posterior capsule. Immediately, I inject viscoelastic into the anterior chamber, come out of the eye, and go bimanual. This is the dictum which is there, very, very important for any PCR or any posterior polar cataract for that matter. And then I put tricot, preservative-free tricot, which I dilute to 1:3, which is available with many Indian companies also. The Orocot is available, and so many other companies are. The Apaswamy is also making it and making it very, very easy. You can see that the rhexis is intact, and go ahead with the cutter first, removing the vitreous which is there, and then removing the cortex. We're doing a bimanual, exchanging from the right to left. The irrigation, I sometimes bring it to the right side. The irrigation, sometimes I have it on the left side, so that I have an access 360-degree without any problem. Again, if it's a small PC tear, you can convert that into a posterior capsular rhexis. This is I think, a very important thing. Don't try to put a lens without converting that into a posterior rhexis. You can see that the small PC tear, I'm trying to convert that into a small rhexis, and going ahead with putting a in-focus lens, which is an extended depth of focus lens, which is made by Apaswamy, and the patient did very well. You can see that when you convert a small PC tear into a posterior capsular rhexis, you can go ahead and put a lens in the bag without any problem, without the fear of any extension of this, the posterior capsular tear into the periphery as well. You can see there's another patient you can see here. I'm sorry, this is not working. Just to show you the FEMTO, the PCR. You can see there's another patient, very hard brown cataract, and probably I did a excess hydro dissection, over enthusiastic. The problem in the FEMTO cataract is you have to be very careful. This is one of the initial cases of my FEMTO. You can see here, because the gas bubbles already do some hydro dissection, and pneumo dissection is already there. I went ahead and did is a very, very hard brown cataract. The pupil is also not very much dilating. I went ahead with the phacomultiplication, but all of a sudden I found the nucleus is not coming towards the tip. If nucleus is not coming to, there's lack of sudden followability. You can see that the lack of followability or sudden loss of followability of the nucleus, that means there is an underlying PC tear. This is a very, very important sign for you to see. All of a sudden, the nucleus does not come towards the tip. It means that there is a PC tear, something is there blocking the nucleus coming towards the tip. As I found out that the nucleus is then also found the nucleus is also sinking, and I went ahead and delivered it because the nucleus, half the nucleus is already outside. Then the remaining nucleus, I tried to extend the incision slightly, and then making sure that I have good viscoelastic cover to the endothelium. And just like you deliver a nucleus in the SICS, I went ahead and did. More important, the reason I'm showing this video is that once you have a PC tear, sometimes the pupil becomes small. Always put iris hooks. If you put iris hooks, then what happens is you know exactly where your sulcus is, where your rhexis, whether your rhexis is intact, and when you put the lens, you can make sure the lens is right there in the sulcus. Again, very, very important. Sometimes the pupil becomes small, you do not know, and sometimes you put the lens into the sulcus, the next day you find that the lens is on the retina. So always when you have a PC tear, sometimes most of the times the pupil becomes small. Always take your time, always make sure that you give if you're on topical anesthesia, give a subtenon anesthesia. Patient is comfortable, you are also comfortable, and also very, very important that you put iris hooks and dilate and make sure that you see the periphery and make sure that you see the sulcus before you put the lens in the sulcus. And this is a very important take-home message I want to give. This is a traumatic cataract in a young patient. In traumatic cataract, there can be a pre-existing PC tear. I did an ultrasound, I did a B scan, I did an UBM, but I was not able to see. But once I removed the cataract, you can see here, this is a very, very soft cataract because the young patient, the 4-year-old kid, and you can see that once I did that, the whole thing started using because of pre-existing tear, because of trauma, there was a tear in the posterior capsule as well. And again, I injected viscoat and then went ahead and did a bimanual and tried to remove the cortex and then remove the vitreous, there, and then try to remove the cortex and put a multi-piece lens in the sulcus and capture the lens into the bag as well. As you know, also patients, and a lot of patients are coming with IFIS. That is, patients are coming with the tamsulosin or the Urimax. It's an alpha blocker, which you take for the enlarged prostate. And you can have a problem of IFIS, that is the problem of the iris coming out, the iris becoming billowing of the iris, the floppiness of the iris, the pupil coming down on you. And you can see this is one of the typical cases of IFIS, wherein the iris starts coming out through all the pores. And what do? You can see this iris shaffing can be there, and especially when the pupil is very small. And these are patients, we're seeing this patient was taken a long time back, even before the IFIS was discovered by David Chang way back in 2005. But these are the older patients. We didn't know at that time what was happening to these patients. Once you have a thing, and this is just to show you a FEMTO, but just to show you a patient who's on Urimax, I tried to do a FEMTO, and we can see that the iris is coming out. Okay, I always inject a viscoelastic, which is like viscoat, which I try to push the lens, or a Helon GV is also very, very useful in this, because heavy molecular pushes the nucleus. I use something like a shaft shell technique, but you can see trying to push the iris back into this thing. But more importantly, these are the patients right in the beginning of the surgery use iris hooks. Very important, because this pupil is definitely going to come down on you. And once the pupil comes down on you during the surgery, it is going to give all the complications. Complications like iris shaffing, the posterior capsule rupture, and the zonular dialysis, hydrodialysis, bleeding from the iris, and all these problems can occur because of that. And you can see that once I found that the pupil is coming down, the iris is floppy, I found. So my cutoff level is about 6 millimeter or 6.5 millimeter. In the beginning itself, I put the iris hooks or the Mulligan ring or a BX ring, whatever you're comfortable with. If you have small pupils like this, a posterior syncytial and pupillary membrane, a post-uveitic cataract, always try to remove the membrane. Under the microscope, these membranes are not seen on the slit lamps, but many of these membranes are being seen under the microscope. We will remove the membranes, then you can probably, the pupil will expand a little, then you can go ahead with using iris hooks. When you put the stab incision for the iris hooks, make sure that it is on the limbus, not in the cornea. If you put it on the cornea, the whole iris will start tinting up. And once you put the iris hooks, sometimes you put the 4 iris hooks or 5 iris hooks, you can see here, very easy. It makes the life very, very easy for you. And the rest of the surgery becomes just like a routine surgery. And you can see that you take your time right in the beginning of the surgery, because after doing the rexis and putting the iris hooks is so difficult. Sometimes the rexis can get caught in the thing. And again, you can see here, just to show you the different types of rings. One is iris hooks, another is a Mulligan ring. Always make sure that you put some viscoelastic underneath the iris to get the iris forward, and then making sure, as you know, it is like a safety pin. There is an injector, and in my opinion, these Mulligan rings are very good, but removal of the Mulligan ring is more challenging than putting it. Okay, you can see the perfect pupil can come in this. There is no traction on the pupil like the iris hooks, and the pupil anatomy is maintained to a large extent. And this is a fairly brown cataract, you can see here, and it makes life very, very easy when you put the Mulligan ring. Or you can go ahead and do what is called the BX ring as well. You can see this BX ring, and again, putting the viscoelastic under the iris. This is a fantastic innovation by Suvan Bhattacharjee of Calcutta. You can see that this is a very, very thing, and it gives about 5.5 millimeter rexis, 5.5 millimeter pupil, which is good enough because your axis is going to be around 5 or 5.25, and it makes the life very, very easy. But we can, the advantage is the maneuverability of this ring is very, very easy. And also this ring can be used through the main port and removed to the side port as well, and it makes the life easy. If you don't have any of these access to any of these structures, any of these devices like the iris hooks or the Mulligan ring or the BX ring or whatever it is, then you can do what is called the pupil stretching. You can see here, this is a pupil stretching you can do. I'm opening up the pupil, Sinus all round, and then I'm doing with the 2 wire rotator and doing the pupil stretching. Only thing is, don't do the stretching in the axis of the incision, because the stretching can make the pupil a little atonic, and the anatomy of the iris can also go ahead and do this. This is a fairly dense cataract. This is a pupil stretching, was done long time back, and nowadays I'm not doing the stretching. But sometimes very small pupils, when you want to use the BX, you can do a minimal stretching and go ahead and do the thing. Sometimes, many times, 5 iris hooks works very well. This is a patient who had a VKH syndrome with a complicated cataract. Can see here, dense sinus. The sinus, not only the entire iris is plastered to the surface of the lens as well, and I had to open around, all round, and you can see here, I'm trying to do that. I'm putting the 5 iris hooks, which actually gives less traction on the iris and maintains the anatomy of the iris, anatomy of the pupil as well, and which is very, very easy. The take-home message is iris hooks has to be done in the beginning of the surgery, making sure that your stab incision in the posterior limbus, a little oozing will be there. Don't make it on the cornea, otherwise the entire iris will start tenting up in the sink. Nucleus drop, as you know, is a nightmare for phaco surgeons. The incidence is about 1.1 to 2%. More commonly, posterior polar cataracts, hydrorupture, when you have a small rhexis and a big nucleus, capsular tear, and which extends to the posterior thing, as I told you in Argentina flag sign, or when you have a posterior capsular rent, the whole nucleus can go in. You can see here, this is a patient who had a dense brown cataract, probably had a hydrorupture. My assistant puts viscoelastic on the cornea, and you can see the entire lens disappears into the vitreous cavity. And this is very important. If you try to chase this nucleus, then you are in trouble. Don't chase this nucleus, which goes into the vitreous cavity. There's another patient who had a posterior polar cataract, can see here. Probably I didn't realize it was a posterior polar cataract. As soon as I did a hydro dissection, can see this is a patient is thing, and it goes inside and drops into the vitreous cavity. Then you have to refer it to the posterior segment surgeon. Since I do both anterior and posterior segment, it makes my life easy for me, and clean up the anterior segment and go in and do a thorough vitrectomy, make this nucleus mobile, and then I'm using the sleeveless phaco tip itself as a fragmentome. I'm bringing this nucleus up. Being a posterior polar cataract, the nucleus is not very hard, so I'm bringing it up and then supporting that with the endo-illuminator. I'm bringing it up into the pupillary area, into the anterior chamber, and trying to phaco-emulsification, do the phaco-emulsification there, and then went ahead and put a lens in the rhexis margin in the sulcus as well in this patient. But if you have a nucleus which is not going inside fully, it is there in the anterior, in the pupillary area or in the anterior vitreous, then you can do what is called the anterior assisted levitation, or ARL. The anterior assisted levitation is just like bring the nucleus up and then deliver it just like you deliver your SICS nucleus, and then put an anterior, making sure that you clear up the anterior the vitreous. I'm using the preservative-free tricot again. I'm using an anterior chamber maintainer, removing the vitreous which is there. In this case, I went ahead with the anterior chamber IOL because the patient was very old with a cardiomyopathy, and this making sure when you do an anterior chamber IOL, making sure that the size of the IOL is very important, and also clearing up the vitreous which is there, making sure the pupil is round, and don't forget to do an iridectomy. You can see the postoperative patient having fairly good vision and 6/9 vision, and it's about 4 or 5 years follow-up in this particular patient, had cardiomyopathy and died recently. You can see another patient, you can see this is a patient, actually a doctor, and she wanted a toric lens. She required a toric lens, but the nucleus started sinking as soon as I started chopping the nucleus. And then I found the nucleus, when it starts sinking into the sudden deepening of the anterior and posterior chamber, and the nucleus starts sinking, then that is an indication that the nucleus is going into the vitreous as well. As I told you, these are the telltale signs of posterior capsule rupture. And I brought the nucleus up and into the anterior chamber and did an anterior assisted levitation and making sure that viscode, and this is a sandwich technique which you use for the Phaco, for the SICS as well. And I went ahead and removed the nucleus and then removed the vitreous which is there in the anterior chamber by using the anterior curve. Don't remove the vitreous with the sponge or the Devicus or the Devicus scissors or something, or the Vana scissors or something like that. Always use a cutter and remove the vitreous, and went ahead with the lens in the sulcus in this patient. Patient did very well. Again, this is another patient. You can see here the lens is there. It is not completely gone into the vitreous cavity. Then you can do a pars plana assisted, or what is called the PAL, posterior assisted levitation, go through a sclerotomy, which is about 3.5 millimeters in the limbus. Make a myrigotomy. With the myrigotomy, you can make a sclerotomy into the vitreous cavity and bring this nucleus up. And the patient, you can see that, again, another patient who had this thing can do I went through the pars plana. Only thing is, don't attempt this PAL if the nucleus is completely going inside, or pieces of nucleus are going inside, or younger patients who got high myopia. All these patients with the posterior capsule rupture or nucleus drop, make sure that you follow these patients, because these patients have got increased incidence. The endophthalmitis also. I always suture all these wounds when I think. This is again a patient that had traumatic subluxated cataract. You can see here the inferiorly there are about 4 or 5 clock cars. I did a fairly good rexis. This is a patient who had a shuttlecock injury long time back, and I went ahead and I put a CTR in the beginning itself because I wanted a circumferential stability, and they went ahead with the Phaco emulsification. When I found the Phaco emulsification, all of a sudden I found that the nucleus is very wobbly. The nucleus is moving around in the bag. So I went ahead with the iris hooks. If you use iris, you can use iris hooks for the capsular bag, but there are capsular hooks which are very, very, very special, which are available, which can be used for the capsular bag. If you're going to use the iris hooks for the capsular bag, make sure, because you don't keep it for a long time. So you can see here I'm going ahead with the Phaco emulsification and without any problem at all, and injecting viscoelastic now and then into the anterior chamber. Injecting again viscoelastic, and then went ahead, and you notice this the lower left, the iris hook. I should have removed the iris hook at that time. That was actually producing. Please understand, if you use iris hooks for the capsular bag, the iris hooks rest on the capsular margin, and there's a possibility of the capsular rexis tear. You can see it has torn the capsular rexis margin and gone behind, and there was a vitreous loss as well. And I went ahead and did an anti-vitrectomy, and then I thought I removed all the vitreous and went ahead and put a multi-piece lens in the sulcus in this particular patient. But more importantly, you can see that I found that vitreous is there still, and then I did a pars plana. I can see that where I did put a trocar and cannula, and the pars plana approach of removing the vitreous. This is a newer thing wherein it actually makes more sense to remove the vitreous from the pars plana. Only thing is you need to put a trocar and cannula. I put a tricot in the anterior chamber. You can see I'm putting a trocar and cannula into the vitreous cavity and removing the vitreous from behind. You can see the lens is stable in the sulcus, and the patient did very well. And again, a Morgagnian cataract. I'm going out with the capsular rexis margin, this thing, and then you can see the nucleus is wobbly there. It's moving around. Nucleus, as you know, in Morgagnian cataract, these are the capsular hooks. These are the capsular hooks ideally have to be used for the capsular bag, because these rest on the equator, and there's a less possibility or no possibility of the capsular rexis getting torn with the capsular hooks. You can see that I'm going ahead with the Phaco emulsification and without any problem, and then putting the making sure I bring the lens up a little, making sure now and then I inject viscoelastic. Then I put a CTR into the bag, because the bag was also a little wobbly, and went ahead with the Phaco emulsification without any problem. Again, intraoperative zonular dialysis, again a very, very common, not an uncommon issue, especially with the harder brown cataracts. The zonules are a little weak. The posterior capsule is also a little fragile. I'm going ahead and doing, you can see that posterior, as I'm removing the nucleus, there is a zonular dialysis inferiorly. And immediately what I do is expand the nucleus, expand the bag, always before putting the CTR, expand the bag with the cohesive viscoelastic like Hyalon, and then once I put the CTR, I put the iris hook there to support the bag there and go ahead with the Phacomorphication. So you put the iris hooks there to support the bag. There's a CTR which gives circumferential stability. There is a radial stability also, and it makes life easy for you. And you can try to bring this nucleus into the iris plane and go ahead with the Phacomorphication. During the IA, don't be complacent, because that is the time you lose your concentration. You can see here that is a zonular dialysis along because there is an excessive pull. You can see that during the epinucleus and the cortex removal, the bag is also coming along with it. This is not an uncommon problem. You can see that zonular dialysis there. And what I do is I immediately inject viscoelastic, preferably a cohesive viscoelastic. This is where Hyalon plays a very important role. And then I'm putting the CTR through the side port from the opposite quadrant. And you can see that I'm putting the CTR. As I'm putting the CTR, I'm making sure that the capsule, that is the CTR, goes into the bag very nicely. And then the rest of the surgery becomes easy. You can see the zonals are gone back and the patient went ahead. We put a lens, single piece lens into the bag without any problem. You can see that without any problem, the multi-piece lens into the bag without any problem in this particular case. Again, a subluxated cataract. If a subluxated cataract, if there is more than 4 to 5 clock hours, then I would put a Sioni ring. You can see the Sioni ring. You need to fix the Sioni ring. So I make a groove, which is about 1.52 millimeter from the limbus in the area of the zonular dialysis, and then put the Sioni ring and try to put the Sioni ring so the sutures can be put there, and making sure that when you remove the cortex, because the CTR traps the cortex, very difficult to remove the cortex. And as I'm putting the Sioni ring, I'm tightening the suture there, then cutting it and then putting the knot under the groove as well. You can see the whole bag goes back, and the area of the zonular dialysis gets corrected beautifully. Once you do that, the bimanual IA is probably the way to go to remove the cortex, and then go circumferentially. When you have a CTR in the bag, always go circumferentially and not radially. If you go radially, the CTR traps the cortex, and that makes life very, very difficult. Always go circumferentially along the equator, and then the cortex comes out very, very easily. This is a patient who had a microspherophakia. As you know, in the microspherophakia, the problem is the zonular dialysis or the universal or the 360-degree zonulopathy is there. So went ahead and did a CTR right in the beginning of the surgery, and then supported the capsular bag by means of the iris hooks. And a fairly young patient, so fairly soft cataract. So far, so good. Everything was going on very well. And then went ahead and put a single piece lens into the bag, thinking that this patient will do this thing. As I'm putting this single piece lens and trying to do the cortex removal, viscoelastic removal, you can see that the whole lens starts decentering. And what I do is immediately the vitreous also starts coming out. Now I have a CTR in place. I have the single piece lens also. I immediately made these two flaps because I prefer doing glued IOLs for these patients, because glued IOL is a secondary IOL. This thing, scleral fixation. Nowadays I've stopped doing these sutured IOLs and scleral fixation. So I always do this glued IOLs. You can see here, I made the two flaps, and then makes life easy. And this patient has got about 3-year follow-up with a 6/9 vision in this particular thing. Again, I don't want to show this, just to show you a traumatic cataract, the total almost 180-degree subluxation. I thought I'll be able to, because it's a very soft cataract, young individual, 25-year-old who had a bulgur injury. I thought I'll be able to emulsify this thing, but I was overconfident. Don't be overconfident. That is what is this thing. But I always plan for a glued IOL also in this particular case, because I know this patient will not have proper capsule because there's a trauma which is extending, quite extensive trauma. But the whole nucleus starts, the half of the nucleus starts going into the vitreous cavity. When it goes into the vitreous cavity, don't try to chase this nucleus. If you try to chase this nucleus, we'll end up in a blessing. So went ahead and did an anti-vitrectomy and put a multi-piece lens Always use multi-piece lenses for the glued IOL. Went ahead to the glued IOL, and then subsequently you can see that I already have a pars plana infusion, made 2 more ports, 2 more sclerotomies, and went ahead and did a pars plana vitrectomy and removed the nucleus as well. Again, a patient who had a phacomorphic glaucoma, and you can see here phacomorphic glaucoma. As you know, there is a zonular dialysis also. Very difficult because the capsular cortical adhesion, very difficult to do a capsular excis. And again, I'm trying to use iris hooks for the expanding the pupil, and going ahead with the phacoemulsification. Once I went ahead with the phacoemulsification, I found that the whole nucleus started sinking. So when you have a problem like this, don't have any doubts. Don't try to convert. You can see here, if I had proceeded with the phacoemulsification, I would have had a nucleus drop. So I went ahead and converted this and brought this nucleus up into the anterior chamber and did what is called something like an anterior levitation. And patient, of course, was a very old patient. So the entire capsular bag, because the patient had pseudoexfoliation, phacomorphic glaucoma, and came out with this. Traumatic cataract, can see there's a corneal tear as well. The young fellow, 8-year-old with a stick injury. Once I sutured the corneal tear, there was an Argentina flag sign because of the stick injury. You can see that on the anterior capsule. And being a young fellow, is only a irrigation aspiration, which you can see the Argentina flag sign right on the anterior capsule. But more importantly, you can see that I'm just removing the cortex without any problem, injecting viscoelastic every time I come out of the eyes to stabilize the anterior chamber, because I don't want the rexus, that anterior rexus, to extend posteriorly. Then I try to convert it into a semicircular rexus on one side and semicircular rexus on the other side. And I went ahead and put a single piece lens into the bag. IOL exchange, if you have a problem of IOL exchange, always what I do is I bring this IOL, this patient by mistake, instead of 16, we put 26 diopters, and we had to do the IOL exchange, and went ahead and did an IOL exchange. What I do is I bring this IOL, make sure that I have a good viscoelastic like Hyalon, and also good viscoelastic to protect the corneal endothelium like Viscoat, and always put the second lens and into the bag. I use the first lens as something like a scaffold, because while removing the first lens, I don't want to, I want to make sure that I don't rupture the posterior capsule, which will make life very, very difficult. The whole battle is lost. And then went ahead, this thing. So the second lens is put into the bag. Now I'm very safe. And then I bring this lens and cut this lens into 2 halves, and then bring this lens into the, through the wound. And I have not extended the wound at all. Probably from 2.8, I have extended to about 3 or 3.2, which means that even through a small wound, I was able to remove this lens. And also making sure the posterior capsule is intact, because I put the second lens into the bag before I removed the first lens from the anterior chamber. Again, expulsive hemorrhage, nobody wants to face this. Just to show you an expulsive hemorrhage. When you have an expulsive hemorrhage, what you do is you have become jittery, and all of a sudden, very rare with Phaco, which has happened to me also long time back. This is to show you an expulsive hemorrhage during a PK and SOR. You can see the whole thing. Once I do the expulsive hemorrhage, just try to, because this is a PK, when you have a Phaco, you can use the thumb or use something like a kuchi or a cotton bud. You can see that the whole thing can be seen, and try to close up the wound, and don't try to drain this thing. The whole concept of draining the expulsive hemorrhage is gone. Only thing is you need to have serial ultrasounds, put the patient on systemic steroids, serial ultrasounds, and once the clot liquefies, then you can go ahead and drain the expulsive hemorrhage, making sure that you take care of the inflammation, take care of the intraocular pressure, and all these problems. The take-home message is, as far as handling Phaco complications, I try to cover as much as possible. Prevention is better than cure. Prevention, of course, anticipation of the complications in situations like posterior polar cataract or heart-bound cataract, pseudoexfoliation, small pupil, recognition of these complications much earlier, and then management is also very important without losing your cool, making sure that because your adrenaline is flowing at that time, you may be operating on a VIP or a doctor, and all these can produce optimum results, and we're making sure that 6.6 and 6. Don't forget these patients require much, what you call, more regular follow-up, much more frequent follow-up in the postoperative period. Once you have PCR, please understand the incidence of endophthalmitis can go up 4 to 5 times. And always I prefer, my message is that try to suture all the wounds if possible, because there can be micro leaks that can lead to endophthalmitis. Again, I would like to thank J&J for this wonderful opportunity. And this series has been a fantastic learning experience for me also. Stay home, stay safe, stay healthy. I'll stop sharing the screen now. Over to you, Satish.
Yeah, yes. Thank you, Professor Mohan Rajan, for an excellent presentation. Those were really wonderful videos. We saw so many of them that we don't know where to start questions. So I'll just put up a few questions that came on our chat box. Maybe we can just cover a few of them. So one of the questions is about your preference of rings or hooks. Would you prefer B hex or Malugan or the I ring?
No, I would prefer the hooks. Then second choice will be BX. I don't prefer the Mulligan ring. For simple reason is because it's a little costly, number one. Number two is I find that Mulligan ring, removal of the Mulligan ring is a little more problematic than putting, at least in my hands. The BX ring is a really, very safe. Putting and removal of the ring is very, very easy also. BX ring a little more malleable than the Mulligan ring. My first choice will be iris hooks. And the second, because iris hooks, I can put it at any point of time. Yeah, if I want during the surgery, all of a sudden the pupil comes down on me, iris hooks I can put. But the BX may be a little problematic. Still, you can do it. I've seen some people doing it. I've seen some videos also by Suven, which can be done. But these are my two choices, I would say. Eye ring is a little bulky, and I would not suggest that. And these are the, as of now, two choices. If I have access to iris hooks and BX ring, I think that will cover the entire this thing in this particular.
What's your experience with this phenocaine injection that has come recently?
Yeah, Phenocaine Plus is available with the Entourage Pharmaceuticals. You can use it even preservative-free adrenaline also with diluted. That also can be used. The Phenocaine Plus can be used, but these are all for. Please understand, you cannot have a pupil 3 millimeter can become 4 millimeter. That's all. Okay. And the problem with the IFIS is that there can be a progressive meiosis during the surgery. That is why my cutoff is about 6.5 millimeter, depending on the hardness of the cataract as well. Any cataract nowadays, what I do is any 6.5, especially in the patient is on tamsulosin, in the beginning itself, I have my clear plan. That is, I will use either iris hooks or a Mulligan ring or a BX ring for that matter in the beginning of the surgery itself. Because once you do that in the beginning of the surgery itself, that makes your life easy and your mind is also very clear. So you can go ahead with the surgery just like a normal surgery without any problem. Otherwise, what will happen is you put this Phenocaine Plus in the beginning, it will dilate. Then all of a sudden during the surgery, because you're using a little more vacuum, the pupil will come down on you. And whatever viscoelastic you use, a soft shell technique, you cannot keep on pushing the iris back and back. It's very difficult. So because the iris will, once it starts coming into the port, then it becomes a very, very messy affair. And you can see, you know better than me, the iris shaffing can occur, the iris can become very floppy, hydrodialysis can occur, bleeding can start coming from the iris bleeding, and all this. It's a vicious cycle. So we don't want any of these iris structures. And post-operative inflammation is also very high. All these patients have increased incidence of cystoid macular edema once you touch the iris. Please understand that. So this is again a very, very important.
One more question about Sione ring versus capsular tension segment. What's your choice?
Yeah, I use capsular tension segment. I use Sione ring. Just to show you the Sione ring, which is available freely. Capsular tension segment is also available freely. The Venu instruments are making the capsular tension segment a little bigger, but it is working very well also. The capsular tension segment also can be done. And because if you want to see, both work in the same principle, whether you use Sione ring or a capsular tension segment. The advantage of the Sione ring is that sometimes you can have universal zonulopathy. Okay. And sometimes what you see is only the tip of the iceberg. The Sione ring, so if you have only a localized zonular dialysis, which is intraoperative and not because of pseudo exfoliation and something like that, then probably a Sione ring or the capsular tension segment can be used. It's only an individual surgeon's choice, and the capsular tension segment will take care of the localized zonular dialysis, whereas the Sione ring, because it's got the CTR as well, and Sione ring, wherever it is weaker, it will fix up to the sclera. The rest of the areas also it will cover up, because there can be a universal zonulopathy in many of these patients.
Okay. Sir, I think what will be most useful for majority of our audience would be about PCR.
Yeah.
How do we recognize it as early as possible? And what are the important steps in preventing that from extending? If you can repeat that once more, what you have.
Yes, yes. See, the most important thing is, I think I mentioned that in the video as well, sudden deepening of the anterior chamber and the posterior chamber. That indicates there is a PCR. Sudden deepening, okay? Suddenly you can see that the anterior chamber and the posterior chamber will deepen, number one. Number two, sudden loss of fallibility of the nucleus, which means that the nucleus, you are having an aspiration flow rate in a peristaltic mission of about 45 or 50. The nucleus was coming. All of a sudden, the nucleus is not coming towards the phaco tip. That means there is an underlying PCR. Once you know this, please inject viscoelastic, preferably a dispersive viscoelastic, into the anterior chamber and slowly withdraw out of the eye. Okay? Then don't go coaxial. Once you know there is a PCR, suspect a PCR, always go bimanual. Okay? If it is a small PCR, you can try to convert that into a small posterior capsular excess. Always make sure that once you have a PCR, you put in viscoat and make sure, because sometimes the vitreous may come, you may not know the vitreous is there or not. Use a preservative-free tricot into the anterior chamber. That will stain the vitreous. Don't be in a hurry to remove the cortex and the nucleus. Always try to remove the vitreous which is there, first there, and then try to remove the nucleus. Once you have the nucleus, then you can put an IOL scaffold also. You can put an IOL once you remove the vitreous. You can put an IOL into the sulcus and then try to remove the nucleus which is there in the anterior chamber using a phacoemulsification. Otherwise, if it is no nucleus is there, only cortex and epinucleus, try to remove the vitreous and then try to remove the using a bimanual. If you have a bimanual, the irrigation and aspiration, keeping the bottle light very low, using low flow parameters, using an aspiration flow rate which is very, very less, then you can prevent the posterior capsule tear from extending. As I told you, if it's a small rhexis, try to convert into a small tear, convert that into a posterior capsular rhexis. If it's a slightly larger tear, then these are the things you should always see. Always inject the viscoelastic and come out of the eye and shift to the bimanual technique. Use a lower flow parameters, remove the vitreous first, and then remove the cortex and the epinucleus. Then you assess, sit back and assess. If the pupil becomes small, please take your time, put iris hooks, and then proceed with the surgery. Don't try to do the surgery with a small pupil. You will end up in trouble.
Yeah. So I think there are.
Somebody has asked to upload all. Yeah, we are uploading all the in the YouTube. We're doing one by one. The series 4 and 5 3, 4, and 5 are already there in the YouTube, and 6 and 7 will be coming on YouTube. The 1 and 2 will also come very soon. Another few days from now, maybe maximum 1 week, all the 7 series will be available on the YouTube.
Okay, that will be excellent resource material.
Yes. You can access it anytime. You don't have to mention my name also. You can use it whatever you want.
That's very generous. Yeah.
Because I want this to go to everybody. That's all.
Yeah, so our time is coming to an end. I will just like to give some take-home messages from what Sir was giving, just so that it stays with us. When handling complications in phacoemulsification or cataract surgery, it's very important that we sacrifice our ego and we convert when needed. We use sutures always. We don't. So it's all a matter of sacrificing our ego for preventing complications. And as I was saying, whenever we anticipate a difficult case, don't try topical anesthesia surgery. Plan well ahead of the surgery what you would like to do, and that goes a long way in preventing complications. Always be prepared, even if you are expecting the surgery to go uneventfully, be prepared in the sense that you saw in many of these surgeries, so was able to handle it. He was able to go to plan B, plan C, because he had the things ready with him. Viscoat, a 3-piece IOL, bimanual instruments, tricoat, capsular tension ring. So all these must be readily available in your OT. You don't know when you would need them. And my final point would be understand the mechanics, the mechanisms, how the eye works, how your machines work, how each of the steps work, because it is a proper understanding of this that helps you manage when you have a complication. So there is no substitute for reading and understanding the subject very well. And then all these goes behind the scene. You don't see that when the surgeon is operating, but we saw all that during the surgery. So thank you very much, Professor Mohan Rajan, for a wonderful presentation on complications. And I also want to thank the J&J team for making available this wonderful opportunity for each of us to learn from the master.
Can I tell? Yeah, I think all the messages, whatever you have given, Satish, are all golden messages. Very important, because many of us are caught unawares. We do not have this 3-piece lens, and sometimes we put a single piece in the sulcus and or in this thing, and it will go into the vitreous and produce problems later on. So what I'm trying to say is, have a plan A, plan B, plan C for all these patients. Not only all these patients, every phaco, every surgery you do can occur. PCR can occur in any surgery for that matter. Okay, any patient. All of a sudden the PCR can occur. We do not know why it's occurring sometimes. Okay, sometimes all of a sudden there can be a surge, which is a thing. So all these things have to be in your armamentarium. So you have to make sure that your OT staff are also well trained in this. Many times I have seen that your vitrectomy cutter has not been sterilized, and all of a sudden you use your vitrectomy cutter which has not been sterilized, and the patient ends up in endophthalmitis, they get referred to me. So I think this is a very, very sad state. So this is what I think we should all see. Every day in the morning, have a checklist before you start the surgery. Every day have a checklist. As Satish was telling, whether you have a CTR, whether you have a Sioni, something, whether you have iris hooks, okay, whether you have intracameral adenine or phenocane plus or something like that, whether you have Viscoat, whether you have an anterior chamber and iris claw lens or something which can save the situation. Or we were discussing that in the IOL last week on the IOL implantation series last week, that if you have any doubts, just do an anterior vitrectomy, clean up the anterior segment, and don't put an IOL. Don't put an IOL. You can always put an IOL after 2 or 3 weeks when there's a fibrosis or anterior capsule. When you have time to think, you can dilate and can have a look at the patient and can think whether you want to put a sulcus fixation or a retroiris fixation lens or a scleral fixation, either a sutured or a glued IOL or an eminent technique, whatever you're convenient. That's not a thing. But ultimately, it's not necessary. That is why I think Satish beautifully nailed on the head in the sense that don't have any ego. Okay, it is not necessary that you should put a lens. You can always tell the truth. The patient, your posterior capsule has been weak. We have to lose the nucleus. I couldn't put a lens. So I think you have to tell the truths, and nothing wrong in telling the complication, because if you're going to have the complication and you're going to put something, you're adding fuel to the flame. And this is a message which I want to give everybody, whether it's beginners or practicing ophthalmologists or veterans or whatever it is. I think it's very important to have the ego at the back of your this thing, but not bring it to the front at all. And have all your things in place and have a checklist. Have a checklist in the morning itself. When you start your surgeries, have a checklist, make sure that all the things are available. Obviously, for a PCR, you cannot refer it to a posterior segment surgeon. You can manage it yourself without just by following all the protocols, just by making sure that you have preservative-free tricot. You have because all the Phaco machines are now equipped with the cutters. High-speed cutters are available. They have got 23 gauge cutters which are available in all the Phaco machines nowadays. So what you require is just an anterior chamber maintainer and a cutter on the right side, and it will make life easy for you. Anything you want to add, Satish?
Yeah, so one more question has come up on the chat,
Yes.
which I thought was a good question. The question is, how can we practice CTR, hooks, and such devices which are occasionally used?
It's very difficult to practice. I don't know how to practice, but I think you should keep seeing the videos. The videos are available on the YouTube. All these videos, it's not difficult to put a CTR. See, please understand, putting a CTR is not a very major problem at all. Make sure that you expand the bag nicely before you put a CTR. You have a good cohesive viscoelastic. That's why you have to have a checklist in the morning, find out whether you have a cohesive viscoelastic. Cohesive viscoelastic, not necessarily that you have to go to Hyalon, which is very costly. Of course, the J&J people, they're having the Hyalon, but lot of cohesive viscoelastic, lot of Indian companies are making very cheap sodium hyaluronate as well. It is available. So all these things, making sure that the bag is inflated, then it's easy to inflate your. So don't you can insert the CTR through your side port or through your main port. But before that, the most important thing is to make sure that your bag is well inflated and the CTR can go inside very easy. Keep watching the videos, and it makes your life very, very easy for that matter. You have any suggestions for that, Satish?
Yeah, my advice to Rashmi would be the same thing. Just you read up whatever you can about it so that you understand it well, and then watch videos. The more you watch, your brain automatically imbibes it. So we would have recognized during our training. So the more surgeries we watch, it's almost like you're performing half of it because your brain automatically learns in the process. So just keep on watching, and you're learning. And you will be surprised that when you do your first one, it has gone on so easily.
Yeah, because once you are doing your phacoemulsification regularly, putting a CTR is not a very big issue.
Okay, then, so once again, thank you, sir. And
thank you very much. Thank you very much.
Yeah.
Thank you very much, J&J, Raghu, Ashok.
Thank you very much, sir. Thank you very much, sir.
Thank you.
I'll be really missing this from next Saturday.
We all too, sir.
But you know one thing, another 1 week, we'll make sure that because already 3 or 4 available on the YouTube. Another 1 week, we'll make sure that all the 7 series are available on the YouTube. Raghu and Ashok, you have to help me.
Sure, sir.
Sure, sir. Sure, sir. We'll meet on Monday.
Satish, thanks a lot, Satish.
Okay, thank you, sir.
For an excellent discussion.
Thank you, everyone.